Our knowledge and truth for a healthy living is a must. Here are the experts. Here are the facts. Here is what we testify to and speak. This is We Shop Talk.
Greetings and welcome to We Shop Talk. This is a part of our summer series. Of course, we're into fall now, but we'd like to take this opportunity to thank everybody for tuning in with us, sharing our technology, energy, and knowledge. My question to you is, who is the quarterback of your health? I'd like to introduce to you Dr. Akatobi, who is our moderator and specialist from Self-DeKalb Family Practitioners. Good afternoon and good evening, Dr. Akatobi.
Thank you so much, Dwight. And we're here at the Purple Dot Salon, downtown Atlanta, Edgewood, where this is our 6th episode of Shop Talk, where we try to highlight health concerns and health issues as affects the Black community. We are here because it's October, and October, ladies and gentlemen, is Breast Cancer Awareness Month. Our focus today will be to say what the issues are as it relates to breast cancer in the African American community. And we have with us today 4 lovely ladies who are willing to share their stories and their journey as breast cancer survivors. Today, it's going to be a focus on cancer or breast cancer in Black America, with a particular focus on breast cancer survivorship. We know that 1 in 8 women in the United States will have breast cancer. We know that 1 in 3 Black women will have cancer in their lifetime. We know that 1 in 6 women will die from prostate cancer in their lifetime. These are facts. And to help us understand these issues, I'm so delighted that we have with us, for the second time, Dr. Rosebugs Phillips, an outstanding breast surgical oncologist who has been in practice for over 40 years, delivering quality service to the community here in Atlanta. Dr. Phillips is a native Georgian and general surgeon and fellow of the American College of Surgeons, specializing in breast surgery. She graduated from Columbia University School of Physicians and Surgeons in 1977, and in 1982 became the second woman and first African-American woman to successfully complete a residency here at Emory University Surgical Program. Dr. Phillips heads the Metro Surgical Associates, a community-based surgical practice with offices in downtown Atlanta and Latonia, Georgia. And for more than 40 years, she has practiced medicine in the metropolitan Atlanta, serving a diverse patient population, a pioneering physician. She remains at the forefront of breast cancer research and has participated in many clinical trials which have impacted people's lives as it relates to cancer today. Dr. Phillips' achievements are vast. She has received scores of awards, and please just allow me to read through them because I think it's that important to recognize Dr. Phillips' contribution just to uplifting our people and just health in general in this country. Scores of awards for professional excellence and reputation as a first-rate physician. In 1998, she was awarded Outstanding Physician by United Healthcare of Georgia. And 1999, Outstanding Georgia Citizen Award, presented by the Secretary of State, Honorable Kathy Cox. 2002, Spelman College presented her with the Outstanding Achievement and Dedication Award in the field of medicine. The National Coalition of 100 Black Women, Inc., Unsung Heroine Award in 2004. The Atlanta Tribune Hall of Fame Leadership and Excellence in Medicine in 2004. Atlanta Medical Association, Inc., 2009 Physician of the Year Award. The Black Women's Agenda, Inc., Washington, D.C., 2012 Honoree in Health Award. The American Society of Breast Surgeons in 2016, the Arnold P. Humanitarian in Medicine Award. Atlanta Business League induction into the Women Hall of Fame in 2017. American Association for Access to Equity and Diversity Award in 2018. Proclamation of the Atlanta City Council Award in 2019, Southern Christian Leadership Conference 2019 Women Advocacy Award, Andrew Young Community Engagement Award in 2019, Diversity, Equity, and Inclusion Department of the Surgery of Emory University School of Medicine announced the Rosebuck Phillips Annual Lectureship in 2023. And 14 Board of Commissioners in 2024 awarded her the proclamation for the work she's done in breast cancer. Awards and accolades aside, she's widely known for her excellent patient care, and she's committed to community service and passionate about her work in the fight against breast cancer. Dr. Phillips saw the need for a program that would increase public knowledge and awareness for breast cancer to reduce mortality and morbidity of this disease. In 1989, she founded Sisters by Choice, initially formed as a support group for women diagnosed with breast cancer and their families. And Sisters by Choice has evolved now into a multifaceted 501(c) nonprofit organization serving women in Metro Atlanta area. Their mission is to educate the public about breast cancer, join the fight against breast cancer, and provide free breast cancer screening to uninsured women and underinsured women in Metro Atlanta. Realizing that health disparities surround access to quality breast care, in 2015, Dr. Phillips started an initiative to address the disparity by developing a mobile breast unit that travels around the state. The unique mobile breast clinic facilitates remote screening and diagnosis services. It provides screenings, diagnostic services, and treatment referrals, breast cancer education, and access to clinical trials to medically underserved men and women in Metro Atlanta. Until the COVID pandemic, the mobile breast unit had provided approximately 1,000 free breast cancer services annually. The future vision is to extend the mobile breast cancer unit to rural areas, and I can assure you that is already taking place. She has served on numerous committees and boards, healthcare committees, and she's actively involved in clinical research and trials. Her professional affiliations include American College of Surgeons, Association of Women Surgeons, American Society of Breast Surgeons, National Medical Association, Atlanta Medical Association, and she serves as a surveyor for the National Accreditation Program for Breast Centers. She enjoys teaching and mentoring Yorkshire physicians. She loves to golf in her spare time and spend time with her granddaughter. And I can also tell you that she's a huge sport enthusiast. We were talking basketball just before we came on board. And that's Dr. Rosebuck Phillips for you. And I had to go through that. When you put in service for close to 42, 43 years, we need to recognize her contribution and what she is, her dedication and her selflessness. We salute you, Dr. Phillips, for who you are and what you are to us, as a mentor to many of us that look up to you, and for the services that you've delivered. Thank you so much for making our time to join us on this Sunday morning here at the Purple Door. And joining us too, we have 4 lovely ladies, some of whom I've known for probably close to 20 years, who are willing to share their stories. We have 2 sisters sitting here, and I'll have them also say a word or two in just a minute. We have Miss Waller. Hi. Hi there. We have Miss Burgess. Hi. And we have Miss Boucher, Miss Hawkins, and then also we have Mr. Burgess joining on today with us. So, ladies, if you want to say a word just quickly about, just introduce yourself to our audience, your name and when you were diagnosed and at what age, and then we'll move on to bring Dr. Phillips in. So we'll start with you.
Okay, my name is Phillips Burgess. I was diagnosed with breast cancer a year ago.
Okay.
Mm-hmm. And I was diagnosed at the age of 61.
Thank you so much, ma'am.
My name is Minyan Waller, and I was diagnosed in 2012. And call that me.
Okay.
I was in my early 50s.
Wonderful.
When I was diagnosed.
Greetings, I'm Therese Boucher. I was diagnosed in December of 2019, and I was in my fabulous 50s.
Hi, I'm Dolores Hawkins. I was diagnosed in 2023, and so at the age of 72.
She looks fabulous, ladies and gentlemen. So, Dr. Phillips, please tell us what is cancer, and what really is breast cancer.
When we look at breast cancer, you're looking at cells that, for whatever reason, is targeted to start producing cells that change the DNA. The DNA in the cell really and truly helps decide what that cell is supposed to do. So when you start having cells that overproduce, all right, they can be benign or they can be malignant. Cells that are overproducing, reproducing themselves, and they spread and invade the surrounding tissue, those are cancer cells. Benign cells, they grow, and they really and truly do not invade the surrounding tissue. They just kind of push it away, push the cells away. So breast cancer cells are abnormal cells that invade the surrounding tissue, and some of the cancer, depending on the type, can spread from one site, from the breast to other site, whereas benign tumors or benign cells, they do not spread. They just grow and stay in one spot.
Thank you so much, Dr. Phillips. And all the numbers we're going to be quoting today essentially are all from the American Cancer Society, the work that they've done over the years, and also the CDC. So we know that the American Cancer Society is projecting that for this year, there will be amongst almost 120 cases of cancer that will be diagnosed. And we know that breast cancer amongst Black women is the number one diagnosed cancer, about 20% of those. For white women, lung cancer is number one diagnosed cancer, but breast cancer in women, in Black women, is number one. And so of that 112,000, we know that 36,000 plus women of African descent will have the breast cancer. And of those, about 7,000 will die in America this year. And that is why having you ladies here to kind of tell your stories is extremely very important. So maybe we'll start with you, Ms. Boucher. What was it like when you had that diagnosis? Was it a routine test that you had done? And how did you process that first week?
So I took a mammogram, which I encourage everyone to do because it saved my life. My breast surgeon had asked me to come in. My son was home from college, and I said, well, come with me, and then we'll go to lunch, thinking everything was going to be fine. I went in, and I looked at her, and she's always smiling. She said, Therese, I think he needs to come in with you. And I looked at her, and I said, okay. So we walked in, and he was standing up. She said, could you get on the table? I said, no, my son is in here. I'm going to sit in the chair, okay? And I said, just tell me straight. And she said, you have breast cancer. And I said, wow. And I immediately started praying in my head. And my son bent down and he said, you know what? Just like everything else, Mama, we're going to beat this. So for me, it was just a time that I thought, wow, life is good right now. I'm doing everything I'm supposed to be doing, etc. And then it just hit me from anywhere. So at that time I went home. It took me a minute to process. I said, okay, I can look at this and I can see my children, my grandchildren, my godbaby. I have a plan. So I immediately said, nope, I'm going to stop responding emotionally. I'm going to say, okay, I got this, straighten up my crown, take that thug that I have from inner city Chicago and New Orleans, said, it's on. It's a fight and it's a war. And from that day, I just continued to just fight. And I said, I'm going to be here. And I just thank God that I am.
Thank you so much, Ms. Boucher. And Dr. Phillips, so you've already kind of shared with us what cancer is and what breast cancer is. And so how do we stage breast cancer? Because I think the key things that we're going to be looking at today is how do we prevent it? How do we diagnose early? And then how do we treat? So we know that mammograms are very common now, but can you take us through that genesis of what has happened over the last 20, 30 years?
We've made
mammograms and then the staging of breast cancer.
We made considerable amount of progress in diagnosis and treating breast cancer. And more importantly, we made a significant amount of successful progress in educating people and the public about breast cancer. When you're diagnosed with breast cancer in a mammogram, usually this is an early stage cancer. That means you have something that's not palpable. You go in for a routine mammogram, as you did, and we find changes on the mammogram, and that follows by a biopsy and you're diagnosed with breast cancer. The first question women are concerned about when they're diagnosed with breast cancer is the stage, how aggressive it is, and what's treatment. Staging is based on the size of the tumor, whether or not they have lymph nodes involvement, and whether or not it's spread to the lymph nodes or any part of the body. Most early cancers are really local, and that's what you want. Stage 1 cancer is when the cancer is less than 2 centimeters with no lymph nodes involvement and has not spread anywhere outside of the breast and the lymph nodes. Stage 2 is when it is greater than 2 centimeters but less than 5 centimeters, but still local with no evidence of spread to the lymph nodes or outside of the body. When we have secondary changes, that some people present with signs, a large lump, it may have, skin involvement, it may have significant lymph nodes involvement, that's when you're talking about stage 3. Stage 3 disease, and then stage 4 is when the cancer has spread outside of the breast and the lymph nodes. Now, when we look at stage 1 and 2, stage 1 and 2 is early cancer, but both stage 1 and 2 can have lymph nodes involvement. And when they have lymph nodes involvement, we call it stage B. So stage 1A is no lymph nodes involvement. Stage 2B is stage 2 with lymph nodes involvement, whereas stage 2A, no lymph nodes involvement. The same thing with stage 3. You have stage 3 disease, a large lump with no lymph nodes involvement, which is stage 3A, and then stage 3B with lymph nodes involvement, and then stage 4 is when you have cancer that is spread outside of the lymph nodes and has spread to maybe your liver, your lung, and that's very difficult to treat, but it's not impossible to treat, but it's very difficult to treat. So mammograms have made a major impact on early detection. Early detection, when we look at breast cancer, your best defense against dying of this disease is early detection.
Mm-hmm. Thank you so much. And we're going to talk a little bit, we're going to dive into that a little bit more, because we know that even amongst, if you look at women of African descent, of Black women versus white women, Black women are diagnosed at a more advanced stage. And there's also a delay after diagnosis. We know, for instance, that the average age of diagnosis for Black women for breast cancer is age 60. For white women is age 64. We know too that for Black women, when they're diagnosed with breast cancer, the average time between diagnosis to starting treatment is 62 days. That's 2 months plus. For white women, it's half that time. So there's a delay after diagnosis. And if we know mammogram works well, how come only about 60% of women are getting mammograms? Those will be questions for Dr. Phillips. So we're going to come back to Dr. Phillips. But let's turn to the sisters here, Ms. Waller and Ms. Burgess. To tell us what the experience was like when you were initially diagnosed. How did that happen?
Well, of course, I went to have my mammogram done, and I went alone. I had been having mammograms since I was in my late 20s. And this time, they told me that they need to do an ultrasound. And I said, okay, but why? But she wouldn't say anything. She said, let's just do the ultrasound and then, we'll have someone to talk to you. So we did the ultrasound, and she came back and said, you need to stay and talk to the doctor. I said, okay. But the first thing he addressed me with is, why did I come alone? I always came alone because I went before work and I would go, back to work after the mammogram. And he told me that I had breast cancer. And I sat there and just stared at him because I was in denial. And I couldn't ask any questions. I couldn't think. I couldn't process it. I went to my car. I called my older sister and told her what they told me. And I just sat there and cried. And then she told me, she said, you got to get yourself together because you have to, come home. And I did. But I remember my mom, her experience. She was 65 when she was diagnosed with breast cancer. And she held that to herself for several months before we got a call. She received a call, and I overheard the conversation. And I talked to my sisters, and we confronted our mother. And we told her she has to see someone about this. And I thought about that. I said, well, I don't want to wait too long. So when I came back to your office, and you told me that, you explained to me what was going on, and you referred me to Dr. Organ. And Dr. Organ told me that I had 30 days to make a decision as to what I wanted to do. So I went to work and, talked to my manager about it. And this was in October. It was late in the year. No, it was November because I had the surgery in December. And my manager asked me, can I wait till after filing season, which was May of the following year? And I just sat there and looked at her and walked out the office and in disbelief. This is my life. I had a young child. I have 3 kids. My older kids, 2 of my kids were older, and I wasn't ready to leave him. I wasn't ready to leave my husband, my family, and we went from there. But I was blessed because it was caught very early. I did not have to go through radiation or chemo, but I'm still under the care of my oncologist, Dr. J. And God has blessed me, and I'm thankful for that experience, so I can help someone else to encourage other women to get it done and to get it done early. Don't wait. Don't hesitate, because you might be diagnosed with something, but that's not the final word. God has the final word. And he blessed me. He surrounded me with people of faith and of great encouragement, and other women that had went through similar things. And you can go ahead.
Ms. Waller, for sharing your story. We'll go on to Ms. Borges too, as sisters, and also knowing the fact that mom also had this diagnosis. How was it for you, Ms. Borges? And I'll have Mr. Borges also comment as a spouse and caregiver. Because when we go through this journey, it's a journey that involves not just the individual, it's the whole family. It's the children, it's a husband or partner or significant other. It's a community that you just identified, whether it's your faith community that kind of walks through this with you. Very heavy burden when you get that C diagnosis. Knowing that mom had been through that, your sister had been through that, what was that experience when that diagnosis came through?
We had another sister who went through breast cancer as well, our older sister. So we was just getting over her diagnosis, which was 2 years prior, 5 years prior to it. But when I got my diagnosis, I had a mammogram done, and I received a letter in the mail stating that it was abnormal that I need to have another one done. So I went to have that done, and I went by myself because I didn't think that nothing was going to be wrong. I went by myself, and when I went to have the second one done, I was notified that I need to have a third one done. And so when I did get the third one done, my oldest daughter went with me. And, no, I had the second one done. And then I had to have biopsy. And that's when my older daughter went with me. And I was in denial. I was in denial for a long time. I wouldn't talk to anyone about it or anything. And when I got the biopsy done, that brought it to reality. Because right after the biopsy was done, they told me that I can go get dressed or whatever. When I went and got dressed, they said, well, you have to stay here. You have to talk to the doctor. And when I spoke with the doctor, I'm like, no, this is not me. I don't feel anything. So I don't see anything. This is not happening to me. And when I left there, I was talking to my oldest daughter, and she was like, Mama, why is this happening to you? You don't bother anybody. Why is this happening to you? She said, this is not fair. I said, baby, don't worry about it, because as long as I know that you are all right, I would be all right. We're going to come through this. And so I went home. Later on that night, I told my husband, I said, I have something very important to say to you. I was diagnosed with breast cancer. We just looked at each other. We didn't say a word. We just looked at each other. And I think it did not hit me to the point where I can discuss it until we were going to see our youngest daughter in Ohio. And while we was up there, the preparation Dr. Phillips was making, the preparation to have the surgery. And that's when it hit me that this is real.
Yes, sir.
This is real. And the only thing that kept me sound was my faith. And the fact that I had my husband to lean on, because he's been a rock. If it wasn't for him, I don't think I would have been able to go through that. And so that's what happened.
And thank you so much for sharing that. What Ms. Borges didn't say was that she was planning on going through retirement, and she had big plans ahead. And Mr. Borges, we had those conversations about what their plans were, and then this diagnosis kind of then came through. There's no question that having a supportive spouse, because he's been through all of those appointments, even coming to the office regularly, and Dr. Phillips, I'm sure, will comment on that. But Dr. Phillips, can you tell us a little bit more about risk factors for breast cancer? Because here we are, and we're going to come to Ms. Hawkins in a little bit, and also to Dwight. Here we are, we have a family of 3 sisters and a mom with breast cancer. How common is that? What are the risk factors just for the average lady out there who might be saying, what is my risk factor, or what should I be worried about? And just to kind of put some numbers again to be sure we have our numbers right, the 120,000 that I cited initially was for Black women, but Dr. Phillips, of course, is saying clearly that numbers we're looking at is over 300,000, which is probably the size of Savannah. And the number of Black women that will now have breast cancer, about that 36,000 is the size of Kennesaw, right here in the state of Georgia, and of which 7,000 will die. Well, Dr. Phillips will kind of shed some more light on those numbers, but more importantly, too, what are those risk factors? And when should women who might have a family member who is at breast cancer to be worried or concerned, and what would you be your advice to them?
Yeah, one of the things, you know, you have two sisters here, and I don't know when Miss Burgess started her mammogram, but you said in the early, late 20s. And when we look at risk factors, you know, it's no question that family history is a risk factor. But one of the things that just the public needs to understand and really understand that majority of women who are diagnosed with breast cancer do not have a family history of breast cancer. I put breast cancer in 3 different categories. You know, one, most women who are diagnosed with breast cancer, over 65 to 70%, do not have a family history of breast cancer. They have no risk factors that we can identify. That's a huge, huge, huge number of women. Only about 15% of women will have a family history. And then only about 10% of the people who are diagnosed with breast cancer will have a family history, plus it's associated with a gene. So the majority of people who are getting breast cancer today, they are considered low risk for developing breast cancer. When we look at risk factors for developing breast cancer, the number 1 and 2 risk factors, being a woman and increasing age. Those are 2 things we cannot do. Cannot do anything.
Change
your gender. You know, we cannot, you are who you are. So that means that every woman, as we get older, are at risk for breast cancer. And as you said, 300,000 women today will be diagnosed with breast cancer. 3,500 men will be diagnosed with breast cancer. So being a woman is a risk factor. Then you look at your personal history. If you are diagnosed with breast cancer, and each one of these ladies have been diagnosed with breast cancer, they're at increased risk for future development of breast cancer. And then your family history, all right? And then those are major risk factors, all right? And then you look at when you start your menstrual cycle and when you go through menopausal. If you start your menstrual cycle at an early age, and right now, our young kids are starting menstrual cycle, 10 years. Whereas
some people younger. It's amazing how far we've come.
Why that has its environment and also what you eat, all right? So starting at an early age and you have a long, menstrual cycle period, that increases your risk for developing breast cancer. And then we look at a lot of the endogenous things that we put in our cake, At one point in time, when a woman hit menopause, we used to give them, hormone. We prescribed the same amount of, the medicine for every woman if they said they were having hot flashes. Now, we kind of have stopped doing that. We look at their symptoms, and I'm not saying that nobody should be on any hormonal therapy. I'm just saying you have to look at what your symptoms are, whether or not they can be treated, otherwise. And when I say what your symptoms are, sometimes there are significant symptoms. Sometimes, your meditation is off, sleep habits are off. Sometimes women are constantly having, night sweats, and they're just irritable. And so a lot of that you need to look at and decide whether or not you want to go on hormone therapy. And if you do, try not to be on it for an indefinite period of time. If I put my patients on hormonal therapy, I try to put them on for no more than 3 to 5 years, and then I start trying to taper them. And I work with them with their oncology, with their GYN. But again, the number 1 and 2 risk factors, increasing age and being a woman, all right? So every woman is at risk for developing breast cancer. And one of the biggest myths that's out there with most American women is that breast cancer is going to happen it's not going to happen to you, it's going to happen to somebody else, okay? Nobody, thinks about a plan to have breast cancer, and you're retired, breast cancer happens when you're planning other things.
That's correct. Thank you so much, Dr. Phillips. And so we'll come to you, Ms. Hawkins. What was that like in terms of that starting that journey? Because when we talk about breast cancer survivorship or just cancer survivorship in general, it starts from the point at which there is a diagnosis all the way to the end of life. The whole goal at the end of the day is to try and diagnose early, be able to cure the cancer, and then one can have a normal life thereafter. But even at that, anytime there's a diagnosis like that, it affects one emotionally, it affects one physically, it affects one sexually, it affects one financially, it affects one's spouse, it affects just virtually everything when you hear that C word, which again is still extremely very heavy, no matter how you dissect it, whether it's early, late, or not. As Dr. Phillips had alluded to, when you look at breast cancer or any kind of cancer, you're looking at three broad categories. Is it localized, meaning it's right there in that organ? Is it just in the breast? Is it regional spread, meaning has it gone past the breast to go into the lymph nodes? And most ladies will talk about the lymph nodes when we start talking about the diagnosis in itself. And then the last part is it gone distant past the lymph nodes? And so depending upon the state at which is diagnosed, the key to very good outcomes is to diagnose it very early. So, Ms. Hawkins, I know your story is still being told, because it's just in the last less than 2 years. What was it like? Just listening to what other lovely ladies are about to say, Ms. Boucher and the sisters here on the panel.
Oh, okay. Well, it really doesn't matter. Once you hear the C word, I have been going through having mammograms, and I also had within over a year's time, maybe about 6 biopsies, because I have fibroid cysts. And the fibroid cysts, when you have fibroid cysts, it's hard to detect. Sometimes it might detect that it's cancer. So I have been going through that over the years. I guess we could say since I was about 35. So I had let's say maybe 5 or 6 biopsies. And so when it came time last year when I had to have a biopsy, I didn't think anything of it. I had been having them, it was just another form of mammogram. But this time they told me I had to come back again. And after they did the biopsy, I had to do ultrasound. And then they did the ultrasound. And like I said, I went home. I didn't think anything of it. I had them and come out perfect. Not perfect. There was no problem. But this time I was asked to call back in to get ultrasound, another ultrasound. And then, 3 days later, I got the call and they said it was cancer, and it was just me. While I was at the nursing home, I had a sister that was there, and she was going through dementia, so I was there, and it just still took me by surprise just to hear the word cancer take you by surprise, because it took me 2 days to tell my daughter and my husband, because I felt like I had to, absorb it into me, that the C word, because there's nobody in my family had breast cancer. Nobody. So if nobody had it, I didn't know you still had a chance with that, having someone in the family having breast cancer. I thought, if you ain't have nobody in the family that had it, I wouldn't get it. And then like I said, I was over 70, so I was thinking I was in the clear. But then once it was told to me, I had great support. I was going to Dr. Agatoba, and he referred me to just a great, great surgeon, Dr. Phillips. She's a jewel. She took me to the steps and told me everything that I didn't know, because I never read up on breast cancer, because I didn't feel that I was going to get it, because nobody in my family had it. And then as the things went by, I got my chemo and my surgery. And through all of it, I guess I have to be blessed, and also blessed to have a surgeon and gynecologist. I have had no problems at all. No nausea, not being sick or whatever. And I was expecting it. Every time I went, I was expecting. You know how you expect something and it doesn't happen? Because that's what they said. It's supposed to happen. I'm supposed to get sick. I'm supposed to get real weak. But I never did. I had times when I was a little fatigued, but other than that, and then I got the surgery, and after the surgery, Dr. Phillips did a great job. Everything was gone. I still had to finish with my treatment, but I guess I'd say I was blessed, because with everything that you go through mentally, physically. And like I said, my daughter, she's an RN, and her husband, he worked with Dr. Phillips, and then his sister worked in the mammogram, where you get mammograms. So I had a lot of them telling me what, about, and making sure that I go to the steps of taking it. And also, no matter what, you still have that inner feeling, But I never said, why me? I never said, why me? Because over the years, I do see things on the news. I mean, cancer starts with babies. So why me? I'm 70. I'm over 70. So I never asked them why me. But I was grateful that as of now, right now I'm still in treatment. I have about 5 more treatments. And in January, I should be finished with all my treatment.
Fantastic. Wonderful.
So I'm blessed.
Thank you so much for sharing that. So we'll come to you, Dwight. What has there been any experiences, family, friends that have dealt with this disease? And are you surprised to hear Dr. Phillips mention that men can also be at risk for breast cancer?
No, I'm not surprised, but being in the fashion and beauty industry for over 40 years, I've had so many clients to come through these doors, and we are the cosmetology industry are some of the first people that clients share their situations with, whether it's illness, divorce, or whatever the family is going through. We get to be that therapist because they spend a lot of time with us. So it's been so traumatic for me, and I guess that's why I got involved with the health initiative, because that's not my profession. But I've gone through so many situations, from domestic abuse, and the list goes on and on. But everybody's situation is different, and trying to figure out a combination of what works and that will works for everybody, because everybody on this panel situation has been different. And it's just trying to figure out what is that one thing, just one thing that they can all do to prevent it, to get them through it, because I've seen horrible situations where they was just sick. And it was almost like the AIDS epidemic. And they was just sick and couldn't get up, and just horrible. But these survivors, are really, really blessed, because I've seen and horrible situations, and to have the husband, the spouse support. So many people don't have that. Even when your work situations, it's just how insensitive people are about health and health care. So just trying to feel that space, and how we can help and educate, because like you said, the numbers are high, they're not low, and it's just a matter of who is next, where is it, and that's the mystery of this whole thing.
I think
Thank you so much, Dwight.
One of the things is, as far as what's common, that all 4 of the people, what connects them, the point that you made, each journey is different. Each journey is different. But the one thing that connects them is the C word.
That's correct.
That's just an instant bond. I mean, when you meet someone, and I've had patients tell me, you can walk in the grocery store and you see someone, they may have on their pink, or particularly someone who lost their hair, that's just an instant connection with them. That C word is the instant connection. It's just...
And what you've set up, Dr. Phillips, to that point, sisters by choice. I mean, it says it all. I mean, there's a bond that no other person can comprehend. We as physicians or as service providers or medical providers can say all we want, but unless you have a family member or your personal experience that actually you've gone through, it's difficult to really walk in the shoes of the patient. And that's why we're so happy to have Mr. Burgess here as a spouse, a supportive spouse, because I can tell you that every single appointment is there taking notes. What has that been like, Mr. Burgess? Here you are, because you retired, I remember, ahead of Ms. Burgess. The kids were already out of the house, doing very, very well. Both of them, one that did well at Georgia Tech and what is actually studying to be a physician as we speak. And here we were with that diagnosis, knowing, of course, too, that you had your mother-in-law, 2 sister-in-laws that have been diagnosed with that. And she said she told you, and you just were staring at each other.
You know, I seen my role in this kind of vary. It changed. First, I was going just as a supporter, but then I had my 2 daughters start asking me all the questions. So I need to be informed. You know, they asking me, I'm trying to listen to what's going on in the doctor visits, and as my phone blowing up, text messages and questions from my daughter's side. So I got to get engaged. I got to be the pipeline, information pipeline to them, because I knew their concern. I had one daughter living in Cincinnati, feeling like she's in another whole world and outside of the loop. Another daughter that knows just enough about this, who's been a doctor, that she's throwing stuff at me, information, that ask this question. So I said, I've got to get really engaged, not just from support from my wife, but I've got to be an informant to make sure that I understand what's going on and I can relay good information back to them. And what really complicated the process for me is, after my wife's 3rd chemotherapy treatment, and woke up one Friday morning, she can't control her right arm, flopping all over the place, had a stroke. And that really threw another corkscrew in this whole thing. We hadn't finished chemotherapy. We got radiation scheduled. And I know she's real sick now. And I tell you, Dr. Akintobi, Dr. Phillips, Dr. Mamby, her chemotherapist, the coordination, sharing of information made this thing viable for us. I mean, the time and effort doctors put in, I'm talking about overtime, taking care of my wife, I take my hat off to you. 5:30, 6 o'clock on Friday, I'm talking to Dr. Akintobi in his office. He's concerned. He's kind of the point man. He's got Dr. Mamby on the phone. He's talking to Dr. Phillips saying, let's make sure we're all on the same page. That really made this journey work. To see up close and personal these professionals at work, but not just professional, but from a personal standpoint, they care for my wife as if though she was their only patient and she mattered. And I tell you, as a husband, watching what was going on and seeing these doctors go overtime, I spent time in Dr. Phillips' office 7 o'clock at night. You know, she's not in a hurry. It wasn't like we were getting drive-through service. The time that they put and the effort that they put in, as if though my wife was their only patient. I walked away shaking my head, and I share that testimony. I'll lift you up. I'll tell you what, you are God sent to my household, and I thank God that under your care and his healing ability, my wife is here today. And I tell you, as a husband, the appreciation from my wife and seeing what she went through, her strength, and this village with my daughters, I tell you what, I've seen God truly work a miracle in her life. And I'm just overwhelmed by it all.
Thank you so much, Mr. Borges, for kind of sharing that story. And you hear that story too a lot among partners and spouses, but not everybody has that kind of support. It's very important to say that so that our audience appreciates that there are people that go through this journey all alone. And so when you have that support, it's important to be able to share. And it's not just that relation by blood. Yes, the spouse, family members, children, all that important. But then there are lots of other folks who should not be going through this journey by themselves. And that is why these organizations like Sisters by Choice, and you have support groups, are so very important. Just be able to deal with the emotional ramification, the spiritual ramification, the financial ramification. We're saying here now, all these ladies, beautiful ladies, have talked about, okay, I had to go through another mammogram, I had to go do a biopsy, I had to go do this. They were all insured. 20% of American Black women don't have insurance before Obamacare. So we'll come back and talk about that in just a little bit to say, If Dr. Phillips does not provide mammograms for the uninsured, who's going to care for them? You know, will they even know that they even have a lump in the breast? Will they even know that they might be at risk? And by the time they find out, it's late. Part of those reasons we already know. There's structural racism in healthcare. There's no question about it. Socioeconomic status matters. Having other comorbidities also matters. Mistrust in the healthcare system. And we've talked about this, Dwight. Mistrust, meaning people just don't trust the healthcare system. 25% of Black people do not trust medical professionals, period. Is it justified? Yes. Because if we have to go back in history, and we can start from Tuskegee and go all the way back to say, how do we now convince people? But what you've seen here is confidence in healthcare providers, trust in the system, trust in Dr. Phillips. And when I call Dr. Phillips, I know I'm going to get the answers I need. You know, I'm not sending it to somebody else. I will go see Dr. Phillips as a patient. You know, it's that comfort that you have. And so you can then share that with other people. So Dr. Phillips, in terms of, because you hear about different types of breast cancer, because not all breast cancers are the same. And she will talk about what they call the triple negative breast cancer, which is oftentimes the worst type that African-American women seem to have, oftentimes probably maybe by 30% more. There's also the inflammatory breast cancer. What are those different types of cancers, Dr. Phillips? And do we know why our ladies of African descent seem to have the worst type and the worst prognosis?
No, we're really doing a lot of research on triple negative breast cancer, not only in African Americans. There are answers just in general, you know, the best treatment. We do know that all triple negative breast cancers are not bad. There's 4 to 5 different types of triple negative breast cancer.
What is triple negative, Dr. Phillips?
Triple negative, when you're diagnosed with breast cancer, as I implied, you want to decide how aggressive the cancer is. And we look at 3 different markers that tell us, you know, the aggressiveness of the cancer. One is whether or not the tumor is sensitive to estrogen. So when the tumor is sensitive to estrogen, it means it has receptors on the cancer site that if you are on hormonal therapy, if you're taking estrogen, it feeds the cancer and the cancer grows. And we treat those cancers most often with anti-estrogen medicine. Mm-hmm. And those are usually what you want. You really want your cancer to be sensitive to estrogen. The other marker we look at is progesterone. And so progesterone and estrogen, those are the 2 hormones that women have in their system, all right? We're not that, progesterone is not as important as estrogen. And the third one is whether or not the cancer produces a gene that we call HER2/neu. Those cancers tend to be more aggressive than others, all right? So when you say you have a triple negative breast cancer, it's negative to estrogen, no estrogen receptors, negative progesterone, and negative to HER2/neu. And we have found that African-American women have more, 30% of breast cancer in African-American women will be triple negative, all right? Having said that, if we look at why breast cancer women, African-American women are dying, it's not really with the triple negatives. It's with the ER-positive cancers, all right? And what we're finding is that it's all related to the stage. So we go back to early detection. Some cancers, when we say it's stage 1 and stage 2, and we say they're early, it does not mean that if you're doing chemo, you have an advanced cancer. Because some stage 1 cancer, we will do chemo, all right? Mm-hmm. But we're talking about advanced cancer. We're talking about stage 3, where you have a large, tumors greater than, 5 centimeters. Okay? You have lymph nodes involvement. Some early cancers do not have lymph nodes involvement. We use chemotherapy. Why? Because there are other things that we look at. And one of the things that we have a test that tells us not only if a cancer that we think is not aggressive, whether or not it is really not aggressive. And so we do that test, and it'll tell us whether or not it is aggressive. Let's separate those early cancer, stage 1 cancer, whether or not we need to do chemo. So you can have a small cancer that's ER positive, and you do the test, which we call an oncotype DNA, and it shows, or a mammoth print, that it shows that that cancer, although it's small, it has a high probability of recurrence. So if you have a high probability of recurrence, you're going to do everything you can to make sure you decrease that recurrence. Another thing we need to understand is every cancer that was diagnosed, except for stage 0, every cancer, and I'll tell you what stage 0, any breast cancer can spread, okay? I mean, anytime you hear the word cancer, you know, you can say it's local, you know, but it can spread. So you want to make sure when you're looking at all of the parameters, you understand what is the most important thing. And simply because someone say you have to have chemo, that doesn't imply that you're going to, you know,
Have worse outcomes.
and so when you sit down and talk to your oncologist, your surgeon, and your radiation therapy, it's so important for you to understand. As Mr. Burgess said, he had to understand everything. And I encourage people, when you're diagnosed with breast cancer, as all four of these ladies said, they make sure they bring somebody with you when you go to visit the doctor. Because you guys, information goes in one ear and out the other. It's not intentional.
That's too much going on.
Focusing on you. So it's always important just to bring somebody in with you. So when you late at night, you're thinking about something and you say, hey, hon, did the doctor say this? And he said, no, he didn't say that. You sure? No, he did not say that. You know. So yeah, it's important to have, you know, someone that can help, you know, get that information, get the correct information. All right. Did I answer your question?
No, yes, stage 0. We're going to talk about stage 0.
Stage 0. Stage 0, about 60,000 women will be diagnosed with stage 0. Stage 0 means that your cancer is within the duct. It has not spread outside the duct. And those cancers are usually treated with, depending on the size, because they can have a large, you know, stage 0 cancer. It can be large, but the bottom line is it's
still within the duct.
It's early. And when you have stage 0 cancer, the overall prognosis that approaches 100% cure. So those cancers we can cure. We can cure those cancers. All right?
Wonderful.
And when we talk about African American women, what we have to do is really and truly educate. Education saves more lives by educating, because what happens is that some African American women, when you're diagnosed with breast cancer, you want to decide what treatment you want. You want to decide, I don't like this. I'll do surgery, but I'm not doing chemo. I'll do surgery, but I'm not going to do adjuvant treatment, which is usually a hormonal therapy. So if you don't get the standard treatment, you cannot expect the same outcome that we have in white women. Okay? So that's why education is so important, to get women to understand your cancer. As I said, all cancer, every one of you, I guarantee, if I went across, you had a different type of cancer, all right? And every one of you has an excellent chance for survival, because you did what you were supposed to do. You listen. We give you recommendations that we think will give you the best outcome, and then I listen to you, and you tell me what you want. Now, granted, if it's something that I think you should not do, you will have a hard time with me, all right? But at the end of the day, it's not my decision, it's your decision. You're the one that's going to have to live with your decision. So your decision-making process is very, very important, and the only way you can make good decisions is to educate yourself, know what your cancer is, know what your options are, and listen to what your doctors are saying. All right?
Yes. Well said, Dr. Phillips. And so I want you to comment very quickly before we come back to our survivors, just to comment very quickly in terms of the genetic testing, which oftentimes is also common now. If I have a patient who, two things. First, to comment on the fact that we're seeing increasing numbers now in women, Black women, less than 40 years old. The biggest surge that we're seeing is actually in younger women. Remember, the average age of diagnosis for Black women is age 60. But we're seeing a bigger number in younger women. And the question is, do we know why? And number two, are all mammograms the same? You now hear of 3, 4, 5, 3 different advanced mammograms, 3D mammograms, and all that. Are they? What is the deal with that, Dr. Phillips?
Standard, reputable, certified, or breast centers and hospitals, we have all gone to 3D mammograms. 3D mammograms is a digital mammogram, all right? And you get the mammogram that we used to do way back when, like the film stream, you get the, four different, well, on one breast you get two different views. And in addition, you get a tomo. And what is a tomo? A tomo is where we slice the breast, and small, going through, looking at every part of the breast. And it gives us the best possible information whether or not there is anything suspicious for cancer.
Okay.
And granted, when you guys get your mammogram, it'll say your mammogram doesn't tell everything. And you guys have heard all this about dense breast tissue.
Yes.
Dense breast tissue decreases the information that we can get from a mammogram, whether or not it is a 2D or a 3D. But again, most institutions throughout the country are going more to 3D and 2D. And if you have a history of dense breast tissue, 100% all your mammograms should be 3D. Okay? As we get older, our breast tissue goes through what we call an involution, where your dense breast tissue changes to fatty tissue. So when you're younger, and that's why we don't do mammograms routinely in youngsters, because their breast tissue generally is dense, right? And we don't see a whole lot. But as you get older, your breasts get less and less dense. When you have a woman in her 70s and have dense breast tissue with a family history of breast cancer, she needs to be followed very, very carefully. All right? And usually those patients, we get an MRI. MRIs is supplement mammograms.
Okay.
You don't just do an MRI. I have patients come in the office and say, I don't want a mammogram.
Want to do an MRI?
MRI, no. We interpret the mammogram and the MRI together. That gives you an additional best possible screening tool. The other thing, you'll have patients come in and say, I want an ultrasound. We don't do ultrasound. Very few centers will do cold breast ultrasounds. Ultrasounds supplement breast exam. One is, you told me you had a mammogram and then they call you back for an
ultrasound.
Yeah, because they saw something. And it is so important, I want to emphasize as far as mammograms. If possible, you should go to the same center. Don't move around. Go to Gwinnett, then go to
DeKalb.
Don't move around. Try and get your mammograms at the same center, because we look at your previous mammogram, all right? And it gives you the best information, about your present mammogram. The other thing I want to mention about mammograms is that we as physicians, we've been kind of confusing our patients when you get mammograms and when you don't, okay? Every woman, I feel, in the American Radiology, American College of Radiology field, and most of our breast organization field, women at age 40, regardless of what your history is, you should be doing mammograms once a year, okay? Every year. It's not mammograms every 3 or 4 years. You really and truly need to be doing mammograms once a year. If you are at high risk, that means have family history of breast cancer, you really and truly need to sit down and talk with your breast specialist and say, when should I start my mammograms? If you have a history of multiple breast biopsies, again, you need to sit down and say, when should I start my mammogram? All right? But most people at age 40 should, and there's different research going on that says African-American women should start at an early age. Okay?
Thank you so much, Dr. Phillips. And now to our ladies, for two things that I'd like for you to comment on, because I think you all have daughters. What is your message to your daughters? What is your message to our audience? And what, looking back, is been the most challenging in terms of your treatment? So three facets: message to your daughters, message to our audience, and the most challenging part to date in terms of going through with this journey. We'll start with you, Ms. Boucher.
Okay, so I have one daughter, Sojourner, and I think even from the very beginning when I was diagnosed, I just wanted her to understand, and she kept asking me, and I don't know a lot of my family history. I am multicultural, so I don't know my father's family. So they kept asking me all these questions, and I couldn't provide them. I didn't know. So for my daughter, I told her, you know, you are young, but because now this has happened to me, it's very important that you take the time to be able just to do early detection, and not even just with this, just with self-care, because we as women try to pour from a cup so many times that's empty. And I did not want her to repeat my history. So I tell her all the time, as you know, she's in grad school now.
Yes.
And with the baby, or the grown man, but with the baby. And I tell her, I said, you have to take time to take care of yourself, because no one else can do that. And you will be the first one to know what happens to you. So because she's an athlete, sometimes, you know, she's hard-headed, but I try to push her into those appointments. The second question.
The community to our audience, the message to our audience, and then the last part is the most challenging part of your treatment.
To the audience, I would just say, you know, early detection, it has to be our key. And, you know, Dr. Phillips said so eloquently, and you did as well, Dr. Akintobi, the support of one another. I did not have a husband or a partner. I had my children and my girlfriends. My girlfriend, I had breast cancer. She supported me through it the entire time. She had breast cancer right behind me, and lost her battle for the second time because it came back just over 2 months ago. But that connection, for just to be able, even if it's just to scream or vent or say whatever, I think people probably looked at me because I would leave the radiation appointment, sit in my car and talk to myself, and I'd be like, oh my God, you know. But just for the fact, early detection, and make sure you have a support. It doesn't have to be you know, a family member, someone that's related by blood. It's someone that cares for you and wants to know that you're okay. I think the biggest challenge for me, and this may be very different from everyone, just losing my girlfriend less than 2 months ago, I have survivor's guilt. I am dealing with it now because I have met some amazing people who have traveled the same journey as I, but to lay to rest and celebrate a life that was so full, that piece hurt me because she was there for me and I was there for her. But for us to come to this peace and to be able to say goodbye, that's been my biggest challenge. I met a man when I first started my radiation. He was sitting next to me and I said, what you here for? And he said, I have breast cancer. I said, really? and I went home and started researching it. Just the amazing people that I met along the way. But just, you know, unfortunately, he didn't survive. And when my radiologist shared that with me, I'm a crier naturally and emotional. So I think the survivor's guilt has been my biggest challenge. But I think with the other challenge, and I accept this challenge of being not just a survivor, but a warrior. And I fight for what is right and for the individuals that may not have anyone. I talk to everybody. They talk to me because I wear pink all the time. So that's where I am.
Thank you so much for sharing that. I'm so sorry to hear about your friend. We just pray that God and time will continue to help you heal. And there's so many stories like that because it's a special bond that goes beyond anything that one can truly imagine. And so when that happens, you're right. How do you process it, and how do you move on? Again, it's to focus on the good times, and because there will be challenging times, And they'll just continue to pray that God and time will continue to help you heal.
Can we talk about just a minute about men and breast cancer?
Men present with breast cancer the same way women, and we treat it the same way. And it's really interesting. I went to Clay County yesterday. Well, Friday. And I had an event yesterday at Clay County. Clay County is one of the poorest counties in Georgia, and they have 900 people. Okay, and most of them have no insurance. So I went there with my mobile unit to do mammograms.
This is a 4-hour drive, right?
And now it's 3 hours. 3 hours.
So this is a 3.5-hour drive from Atlanta that Dr. Phillips is talking about to Clay County, almost on the state line with Alabama. So with a mobile unit.
There was a young man there, and his dad had breast cancer, and his mother had breast cancer. And so I had a conversation with him, and we were talking about knowing your family history. And knowing your family history is important. And he did not know whether or not his dad had genetic testing. So that's one of the golden rules. If a man is diagnosed with breast cancer, we automatically do genetic testing. So I told him I'll be going back sometime, and I told him I need to know that, because if his dad did not have genetic testing, he needs to be tested. And if his dad had genetic testing, he needs to know the gene that his dad carried. But we were talking about, men are diagnosed the same way as women. Sometimes men will feel a lump because they have less breast tissue. If you have, and also when you get older, you guys have gynecomastia. Sometimes you think it's your chest, but it's, you have breast tissue. And so if you have, some tenderness, if you feel a lump, and particularly if you have a family history, just have it checked out.
So, okay, when you say, how?
And every man in the room did not need, all men did not need screening mammograms that they feel.
Just right.
No, I think if
feeling for, because we don't, not for women, but it's
you're feeling the same, you're feeling up. Just like women need to know their body, men need to know their body. And I encourage my patients to do a breast exam at least once a month. And do they do it? No, they don't. But some of them do. But you just examine your breasts, because you'll know it's just knowing your body.
So is it a certain time or age for men?
You just, every once in a while, just examine.
Do you start at 30? 20?
No. I think, when kids, 10, 11 years, and I've examined kids come in, when men start, they develop, you have some breast tissue. Mm-hmm. Men have breast tissue. And I've had kids, their parents will bring them in because they have a lump and it's just their normal little breast bud, okay? It does not develop like women breast tissue does, because you don't have the hormone, stimulating the breast tissue, okay? As you get older, your androgen, kind of go down, okay? And a lot of men doing their 30s into 50s, you guys are in the weight room, you building up your
pectoral.
And so when you get older, your pec gets slammed, okay?
Why?
And so, you just need to be aware of your body, okay? And more importantly, aware of your family history. And if you have symptoms, any kind of, abnormal pain and tenderness, you have to realize most pain in women is the same as most pain in men is the same in women. It's due to fibrocystic changes in the breast, and you guys have that. And particularly when you're taking in a lot of caffeine, you will get pain and tenderness. I think over the last 5 years or so, we are doing more mammograms in men, than we've ever done. But again, I don't want to have you guys leave here that should be one of your routine screening, along with a rectal exam and a PSA. Okay, no,
we're gonna scare everybody away.
That's not what I'm saying. Okay.
So, but to your point, Dr. Phillips, in terms of knowing one's body, for us in primary care, this is exactly the conversation we have with all our clients, men and women. For men, at a certain age, when you're 25, 30 years old, you need to be able to do a testicular self-exam. Know what the testicle feels like. Know what is normal, know what is abnormal, because at that age, between 25 to 35, there's an increased risk for cancer of the testicle. In women, there was a big push many years ago, Dr. Phillips, and you do recall this well, about clinical breast exam, that every lady that came into our exam room that came for their physical, we had to do an exam, a breast exam. I still do that, even now, as part of my complete physical. But
you guys are told not to, which is amazing. I mean, I tell women coming in the office, and I'm separated, older women, 70, 75, they'll be diagnosed with breast cancer, and how they're diagnosed, because also they stopped doing mammograms. There's nobody examining their breasts, so they'll come in, and they'll come in by their caretaker and say, I saw blood on the gown, or I was helping them with their bathing, and I felt a lump. Those ladies have advanced cancer. There's absolutely no reason not
to have them at breast. Yeah.
The primary care physician, you guys see them 3-4 times a year.
That's right.
Just examine the breast one.
Yeah.
So this is what I teach my patients to do, because if you're having your cycles, okay, which means you're younger than say 50, do your breast exam 10 days after your cycle. Know what your breast tissue feels like. And I teach them how to do what I call breast mapping. That is, when you first start doing your breast exam, just draw a diagram of two breasts. Jot down in your own words, not medical term, what you're feeling. The next month, you examine your breast, jot down what you're feeling, and then you compare the first month you did. And then you do it again and again. By the time the third or fourth month, you know exactly what your breast
feels like, what is normal.
You know exactly. And so that's what so for the women who, and I ask you guys when you come in and see me, when last breast exam you had, who's your primary care physician? Are they examining the breast? OBGYNs, they're examining the breast, okay? But the average primary care physician will tell me that they're taught in their residency, in medical school, not to examine breasts. I don't understand that. I do not understand that. You're missing an opportunity. You guys should know your breast tissue better than anyone. When I had experience way back when, probably third or fourth year in practice, my best friend came in and I examined her, and she was telling me she felt something. Something felt different. I examined her, and when I examined the breast and I don't feel anything, I follow the patient up. So I followed up, and she gets scared. I feel something here. It feels different. And that was when we were not doing needle biopsies. We were taking patients to the operating room. And so that's exactly what I did. I took her to the operating room before I put her to sleep. I said, what you feel? And I made an decision. She had an early breast cancer. She's now like a 30-plus year breast cancer survivor. So what I'm saying to you guys, you know your breast tissue better than anybody else. You should really and truly examine your breast. That's just cheap. You're not paying any money. You're not, just once a month, examine your breast. All right? And if you're not having your cycle, just do it. I do my breast exam monthly on the 12th of each month. My birthday is July the 12th, and you guys can remember that and send me something.
You deserve everything, Dr. Phillips, yes.
So the 12th of each month is when I do my breast exam, that I remember it, And so just please examine your breast.
So to Ms. Weller, and Ms. Borges, and then Ms. Hawkins, just to answer that question as to the message to your daughters, and thank you so much, Dr. Phillips, for just enlightening us there and those personal stories too. Message to our audience and the most challenging part of your journey.
Well, I do have one daughter, and I do converse with her about having her exam, and she does have her exam. And I wish she was more proactive in her body than I was. She always examined her breast. And not only her, I would speak to my other nieces about that. And to your point about, I have a friend that had breast cancer, 3 different types of breast cancer 3 times. she had 5 different types of cancer. And I just spoke with her and, trying to keep her encouraged. But it is a struggle when you do come across some women that never had, in this day and time, never had a mammogram.
Mhm.
And I find that that's strange. And on your point, our mom is 87 years old, and she doesn't have a mammogram anymore. She was finally released from her oncologist. But I do worry about that coming back because I had a mother-in-law, my first husband's mother, that died from breast cancer. She had it and it came back in the other breast, but she refused to have treatment because it made her so sick. And she said it wasn't worth that. And it wasn't worth going through that again because she was only 65.
Mm-hmm.
And, but, I thought, well, you have still a lifetime. And my sister told me that she told her girls that she didn't want to go through that. And when she mentioned that, I was on the phone with her. And that hurt me to the core when she said that she didn't want to go through the chemo. But, my thought was, I want to do anything I can do to survive, and I want to teach my daughters, my sons to be a survivor. Don't give up.
Listen.
No matter what they tell you, don't give up. What was the other one? I'm sorry.
Thank you so much again. And the other piece is the message to the community, I think, which you addressed already, and the most challenging part of your treatment.
The most what?
Challenging.
Oh, my challenge. Well, thank you.
You know your sister.
Mine, I think, tell me if I'm wrong, mine was a 0
Yes.
because it was so
Yes.
early. But I was in the waiting room at Dr. J's office, and this white lady sat next to me, and she was asking me about my breast cancer, and I told her what I was going through. She said, that happened to me. And she said, it's going to come back. It's going to come back with a vengeance. And I just looked at her and, I said, I'm not accepting that. Because your body is different from my body, because I'm one of the ones that keep up with the family history because, growing up, people that when somebody passed, they didn't talk about the reason why.
Mm-hmm.
And I want to know everything. My grandmother, my father's mother had pancreatic cancer, and I want to know, so I can talk to the kids about that. And just this knowledge is important to learn everything you can about what's going on with your body and to do your own research. It's good you all informed us, but we need to go a little deeper than that to get a better understanding.
Yes.
And when I was going through that, my husband was going through prostate cancer. I didn't have time to worry about me. I had to take care of him. And to this day, I'm still take care of him. But we can't forget ourselves. We have to take care of ourselves because in order to help somebody else, we have to be in our best health. And that would be my advice to women, to people, period, to take care of yourself. Go to the doctor regularly, get your checkups, do what you're supposed to do, because true, tomorrow is not promised, but you don't have to shorten your life because of being unknowledge.
Well said. And what you've just described, there's also now what they call the sandwich generation. On one hand, you're caring for parents who might be elderly. You have children who still depend on you, spouses that depend, and one is right in the middle. And that's why at the end of the day, elections matter, because all that we're talking about here too is how to be able to get women that need services who are uninsured or underinsured, like Dr. Phillips having to drive 3.5 hours with the mobile unit to go do mammograms in Clay County. For the uninsured and people who are underinsured, we still have 12%. When President Obama, when they passed the Affordable Health Care Act, 20% of Black Americans were uninsured. At the end of that presidency, it dropped to 12%. For white America, it was 14%. It dropped down to 9%. So we still have 12% of Americans that are uninsured. And even here in the state of Georgia, because we have refused to expand Medicaid, lots of people who will be covered, the money is sitting there in D.C. The money is there. It's been allocated by the administration at the federal level. And for political reasons, we just have not accepted that we need to expand Medicaid to get people covered. Dwight and I and a host of other organizations were at Woodruff Park right here in downtown Atlanta last month, where we saw here in this city uninsured and unhoused Black families. We were there giving free health services right here in downtown Atlanta. If you drive to Woodruff Park, which is only 5 minutes from here, at 7 p.m. in the evening, you're going to be stunned. I mean, and so you wonder, we can talk all we want. If one is insured, you're going to most likely get the service provided. You have a good provider. But how about if you're uninsured? And so even part of the problems we had is after we deliver those services, how do you follow up? We have to now find organizations like the Salvation Army that can say, okay, we know these individuals, and we're able to take off, 6 families off the street from that event. And so these are facts that really have to touch us and let us realize that elections have consequences, and the consequences will trickle down at the end of the day. I'm thankful that you all are insured, and we didn't even talk about the financial burden, because you have to have out-of-pocket costs. Mr. Burgess was recently retired. If you had spouses that were working, they had to take time away from work. You have to take time away from work. Family medical leave is still not all the way across the board, where you can take time and take care of your own health. Whether you have somebody you're caring for or caring for yourself, and that you have that to be paid by businesses and by the government. So we can talk all about the politics of this, and we're kind of slowly going to start to wind down, because I still want to give Dr. Phillips time to tell us a little bit about treatment options and the future. But before we do that, Ms. Burgess and then Ms. Hawkins to yes, ma'am.
My sister, I'll be remiss not to give my mother honor.
Props
For, like I said, she's 87. And no matter what type of surgery we have had, she took care of us. After my surgery, I did not go home because I knew my husband couldn't take care of me. But I had my mother. My sister had my mother, my older sister, and Phyllis, my mother took care of her as well. But one main thing that I would advise everyone to do, share your story with your family. There's a lot of people hold things in. You know, how are the next generation is going to know what to expect or what our experience was if we don't share it? You know, it's a legacy, and
to that point, Ms. Waller, you have to get to a comfort level, because everybody's comfort level is different. The fact that you're here wanting to share this story is not easy for everybody to do what you're doing, because you have to be at peace and to realize all of a sudden, yes, I'm at the point where I can actually then tell people to hear that story. Not everybody gets to that at the same time. Some people is 1 year, some people is 20 years after the fact. But the point that you're making that needs to be said is, whatever that time is, when you get to that comfort level, share that story for others to know that it's a journey, and you can go from a test or trial to a testimony, because that's exactly what you all are. It's a testimony for all of us to know, and that journey is not the end. It's a journey. Just like with life, we'll go through challenges, and how you come out oftentimes depends on how you embrace it. Ms. Borges.
Okay. What I advise for my girls to do is get your annual checkup. Because young people, they just think that they're going to be fine. They're fine. They don't need it. And they're in their early 20s. So I'm like, and I've been trying to instill in them, go to the doctor annually. You're fine, that's good. But if something is wrong, you can get help.
Mm-hmm.
But you have to get it early. So that's one thing I advise any young person to do. Go to the doctor, get your annual checkup. And what's your...
The question to, how do you address the community in terms of what you say to them, and what was the most challenging part of your treatment to this point? I think Mr. Borges addressed a little bit of it, which I am pretty aware of that situation.
Yes, the situation when I was doing chemo, and we was up to, I just had one more to do, and I had a stroke. And after the stroke, it took me a while to recover from the stroke because I had to go through physical therapy and occupational therapy. And so during that whole process, I had not had a chance to do the radiation. And that was the last thing I had to do. And so because of the time, it had pushed the radiation out. So we thought that we were running out of time to get the radiation done because it's only a narrow window. But thanks be to God, he got it in on time.
And you rang the bell.
Yes, I did. I did twice. I ran it for chemo. I was allowed to do it then, and then for radiation. So during that time period, during the stroke, that was very difficult for me because I'm like, it wasn't supposed to happen. How did it happen?
Mm-hmm.
And all these other, and then during that time for the stroke, found out there's something wrong with my heart.
Mm-hmm.
And I'm like, what else can go wrong?
Mm-hmm.
But you're a survivor.
Yes.
I'm a survivor.
Yes. Yeah. Fantastic. Thanks so much for sharing that, Ms. Borges and Ms. Hawkins.
Okay. As far as my daughter, as well, my daughter's an RN, so
at Emory University.
She's an RN at Emory, so she already knew, the procedures and everything. Even though she knew the procedure, what needs to be done, we still got a generic testing because there's no cancer in my family. So she did go through that, and I do have a granddaughter. And we just want to make sure. But like Dr. Phillips said, no one has to have it for you to catch it. I mean, you get it, not catch it, but get it. So my challenge to her, which I tell her every day, she continued to do it and to make sure that she just keep a check on my grandbaby. Because, she's going 13, so she need to be aware of what's going on with her body as well. And like I said to the audience out there, all I say is that, as Dr. Phillips said, get checked. The early detection is the best. I have been getting mammograms and also, like I said, biopsy for so long. I went every year, and then I started going every 6 months due to the fact that they said the older you get, the instant your breast tissues. So I started getting them every 6 months, and that's how but it happened in between those 6 months because that part of it, there was no sign. And the next, and it could have been, I don't know how it grows or whatever, but I'm saying I just had one 6 months ago, it was fine. And then 6 months later, they told me that, I had it. So I feel the best thing is early detection no matter what, just take it, I mean, even if you might have to pay for it, To me, it's worth it because, insurance is awful. I have to say, so far my insurance has been great. And that's depending on my husband's insurance. He worked for the Federal Reserve. So we hadn't had a financial burden, And that's the biggest thing for a lot of people that don't go to the doctor or don't get a mammogram or whatever. If you don't have the finance, it can be very expensive just looking at my bill compared to what my insurance paid. I probably sitting on the line too, At that time, we both was retired. We had been retired for
a while.
For a while, and we weren't thinking
enjoying the grandkids.
Bill that's gonna come up, but I have to say, the health insurance that we have now, took us through it with no financial burden. But to that, and I really didn't have any challenge in my treatment due to Dr. Phillips, Dr. Jones, Dr. October. I really didn't. And people said, "Are you sure?" I said, "I don't know what to expect," but I really didn't. Only challenge I had was at the time that I was going through it, I was also taking care of older sister who was in a nursing home. That was my only challenge, to try to take care of myself and then take care of her, which she passed away, before I finished my treatment. So that was my only challenge, trying to make sure I'm there for her, for myself, and my family. Because no matter what you're going through, you're still, like Dr. Agatobi said, you're still kind of like in the middle with your kids, your grandkids, your husband. You still got to be there for them. And of course, they was always there for me. So I have to say, out of all the cancer treatment and cancer knowledge that really Dr. Phillips gave me, because at first when that triple negative, I never heard of it, but she really explained it to me with all the information. So I have to say, overall, my battle or through this cancer was, I won't say excellent, because no one can say the C word is excellent, but as I said, I had no major problems or anything. And a blessing.
And that's wonderful because, and Dr. Phillips talked about this in terms of treatment. We've come a long ways from where we used to be 20, 15 years ago to where we are now in terms of advances. And before we go to Dr. Phillips, and I want you, Dr. Phillips, just to kind of tell us a little bit of how treatment has evolved and what the future is, and in terms of encouraging people too, particularly Black America, to get involved in clinical trials. We make up about 14% of the American population, but we only have about 7% of us who are involved in clinical trials. We know that, and Dr. Phillips will talk to this too, some medications work well in Black people, they might work well in white people. We know that. As a matter of fact, for some blood pressure medications and other medications, but there's no way to really be able to quantify without getting people tested and being involved in trials. I know Dr. Phillips has been involved in many trials over a career, so to kind of reflect on that. But before we go to Dr. Phillips, because we're going to wrap up, I want to give, again, to thank Dwight so much for hosting this and agreeing to do this. Again, this is the 6th in the series. We're going to be highlighting more health and health concerns. What's your take so far, Dwight, with all that you've heard?
Well, I've just been sitting here and reflecting, and just confirmation from the strength that these 5 women have given and shown. And it's just confirmation that the Black woman is one strong, powerful woman. And I just give you all this honor and the glory and just salute you for being the backbone of our family and our community. And it goes, I'm not going to get political, but it goes all in alignment with what's happening with the world right now. Thank you.
And on that note, Dr. Phillips, as we kind of wrap up, just to kind of give us what the future is, treatment now, we've talked about medication, we've talked about chemo, we've talked about radiation and surgery that you do as a surgical oncologist, and then how do we get many more people to be involved in clinical research, many more from Black America?
Before I do that, I wanted to say that both you guys are talking about the survivor's guilt. That is common. That is common. All right. And I believe strongly that when we have adversities in our life, but particularly when I deal with my breast cancer patients, I always tell them, it's not that you have breast cancer. God gave you this to do something. You got to figure out what you're going to do with it. You have survived. What are you going to do with this? Because your journey is very special, but it's individualized to you, and there's something you're supposed to do with this experience other than just go through it. And that's what each and every one of you have to do. We have come a long, long way in treating breast cancer. I mean, in the early 70s, we were still doing radical mastectomies, and radical mastectomies where we removed the muscles, the breast tissue, and then the lymph node. It was very debilitating for women. And we went through a lot of clinical trials to get where we are now. And we know that breast cancer, for most people, it is in one area, and you don't have to take the whole breast. You can conserve the breast, but some women, because they say, I don't want to deal with this ever again, I want to decrease my risk, they decide to do some unilateral mastectomies and some bilateral mastectomies. And reconstructive surgery has really and truly come a long way. The different medicine that we have, I'm amazed at my oncologists when they tell me the different kinds of medicines that are out there. It's just huge. I mean, we have developed so many medicine. And the ultimate goal for treatment of breast cancer, we want to get further and further to a less invasive treatment. And I think we're going to get there. Mm-hmm. Yes, we need African-American women to commit to more clinical trials. I have a good relationship with my oncologist, and they'll call me when they think there's a patient of mine that will fit into a clinical trial. Then over the last 5 years, I think more and more Black women are entering into clinical trials because they know it's so important in helping us, to find, new ways to treat breast cancer. We have the proton therapy that, I think may become a value. When I say may, because there's so many proton centers throughout the country have closed. Emory opened their proton therapy about maybe 4 years ago.
Yes.
They have clinical trials that we are entering in, but usually it's not for patients with early breast cancer. Mm-hmm. The standard radiation treatment is what we use most often. There is what we call targeted treatment, where women who have very, very early breast cancer and who are over 50 and they're tumor sensitive to estrogen, that we're doing targeted radiation, where we do a lumpectomy and just do target radiation to that little spot. Whereas most women we do toned breast radiation. I think targeted radiation is going to help us minimize, what we do with patients when they're diagnosed with early breast cancer. And that's our goal, to see if majority of cancers that we're diagnosed today, early breast cancer, because they give us a better overall prognosis for cure.
And it's so amazing too, the fact that there's exceptionally good, money is now that is spent onto cancer research, or like other forms of research, whether it's a Komen Foundation or women stepping up. And when you see that pink color, everybody knows what it is. So when next you see somebody with a pink color, you better stop and ask or give them a hug and just check to see how they're doing. There's still more that we still need to do, because again, we've said too that the number of women, African-American women diagnosed with early stage breast cancer is still too little. We're still getting more and more diagnosed at an advanced stage. And when it's advanced, the treatment outcomes are poorer. The likelihood of dying from it is poorer. The likelihood of having 5-year survival is poorer. Mammograms works well, unlike other forms of cancer where there is no screening. We can't screen for pancreatic cancer, for instance, but we can screen for breast cancer. Yes, we've come a long ways, and thanks to the likes of Dr. Phillips in this field. We salute all that they've done. And but to see the smile despite the trials on the ladies who have been here to share their stories I can't thank you enough for joining us today and for letting our audience see too that there is light at the end of the tunnel. Yes, it's challenging. We're not downplaying that at all. But that when it's all said and done, one is still standing with a smile and letting the generation behind us understand what needs to be done and what they need to do. What we didn't talk about today too is even issues like the genetic mutation, like the one called the BRCA gene, because increasingly to some women that may have that BRCA gene might be opting to even have both breasts taken off, and Angelina Jolie popularized that a couple of years ago to say, if my risk is high, I can just take the breast off. And I'm sure Dr. Phillips can comment about that too at some later time. So the bottom line is to make sure that one is getting the information that one needs and then following through. It starts with being insured, very important. And if one is uninsured, there are services here, even here in the city of Atlanta and beyond, where you can get those services at no cost to you. Dr. Phillips' Sisters by Choice is a good example. Fulton County also offers free pap smears, free mammograms. The events that we're doing around the city also offers free prostate, free colon cancer screenings, and then to be able to follow up and then really see the population who is at risk, the uninsured, the unhoused, and then a lot of people who are also underinsured. And from a political standpoint, we need to keep pushing the government. Georgia is now number 3 in the country in terms of the uninsured. And because a lot of states in the South, for political reasons, have just not expanded Medicaid. And that, of course, will have big consequences in terms of health outcomes. Well, thank you again for joining us on this special episode of We Shop Talk, focusing on breast cancer, because October, of course, is Breast Cancer Month. Again, the pink is the color of breast cancer awareness. And so where you see ladies with that, it has some significance. Check in with them. And please also do know, too, that this is a continuation. In the coming months, we'll have other health concerns that we'll be addressing, whether it's issues relating to weight management, because now we have medications that work well for our community, and then talking about issues relating to heart disease and preventing heart attacks and strokes. We've had that as part of our conversation today, as Ms. Burgess has been through that, and she's here standing as a witness. We have many other examples around us when services are taken or things are done appropriately and effectively, and that outcomes usually are very good. We can't thank Dr. Phillips enough for making our time out of a very busy schedule to be here with us. Dr. Phillips, we salute you. We'll remember July 12th to make sure we get something to Dr. Phillips. Just a lot of hugs and flowers, more than just flowers. And to you, Mrs. Burgess, thank you for sharing your story and the story of your family, Miss Waller, and what Mom has been through, and the rest of the family. Well, thank you for being here with us, Mr. Burgess. The support that you have to your wife is exemplary, and so we hope that folks can learn from that to say that it's a journey you walk through together. Ms. Boucher, we're sorry again about your loss, and we thank you that you were able to make it from South Georgia to be here with us today, where you're also still sharing this story of what your journey has been through. And Ms. Hawkins, too, we thank you so much. And to our host, Dwight Eubanks, we can't thank you enough. Thank you so much for all that you do. We'll turn the microphone to you, Dwight, so you can take us home.
Well, it has been a pleasure, and thank you so much for tuning in. Until we meet again, farewell.
Now that you heard the facts, apply the knowledge. Contact your doctor or healthcare specialist. Scan the QR code to provide more information on today's talk. See you on the next We Shop Talk.